Imagine it's midnight. A family member's chest suddenly tightens, and they collapse. You call an ambulance, but it doesn't arrive. You find yourself rushing them to the nearest public hospital in the back of a bouncing three-wheeler. When you arrive, there isn't an empty stretcher in sight. The ward is overflowing, patients are sharing beds, and the staff is visibly overwhelmed. This is the reality for millions of families facing a medical emergency today. Yet on the other side of town, the picture changes. This creates a divide where geography and personal wealth dictate whether a person survives a treatable illness. To understand why the system struggles, look at what wins elections. Political campaigns are usually fought over roads, electricity, or religion. Because healthcare access hasn't historically determined how people vote, it hasn't remained a top priority for leadership. For decades, India's public health expenditure has stayed at roughly 1 to 1.5% of its gross domestic product. That narrow financial pillar supports a population of 1.4 billion people. This funding level creates a persistent strain. In a typical government outpatient ward, a single doctor might see hundreds of patients in a single shift, making detailed consultations nearly impossible. The impact of this funding gap is most visible in rural regions. While cities have modern complexes, thousands of rural health clinics attempt to operate without consistent electricity, clean water, or functional equipment. Without voter pressure to fix these local clinics, the government lacks the incentive to rebuild the foundation, leaving the poorest families with the fewest options. It is often assumed that India simply doesn't have enough doctors. However, data shows the country actually meets the World Health Organization's standard of 1 doctor for every 1,000 citizens. The real issue is where those doctors are. Roughly 80% of India's doctors practice in urban centers, leaving the vast majority of the population in rural areas with very little coverage. This is especially true for specialists. Surgeons and cardiologists are almost entirely absent from rural districts, forcing patients to travel long distances for life-saving procedures. There is a practical reason for this. A doctor who has spent years in training is unlikely to move to a village that lacks decent housing, schools for their children, or the medical tools needed to do their job. Meeting a statistical target on a national level means very little if the medical staff is concentrated in a few cities, far from the people who are actually sick. Because rural clinics are often empty, families are forced to travel to urban private hospitals when a crisis hits. This shift to the private sector brings a heavy financial burden. About half of all healthcare spending in India comes directly out of the patient's pocket, often wiping out years of family savings in a few weeks. To combat this, the government launched the Ayushman Bharat scheme, a public insurance program designed to provide free hospital care to millions of low-income families. The program has saved lives, but it has limits. Many private hospitals decline these patients because government reimbursement rates are low. Additionally, the plan covers hospital stays, but ignores the daily costs of doctor visits and medicines. There is also a secondary crisis that often goes unmentioned: mental health. Millions deal with depression or anxiety, yet psychiatric care is almost entirely absent from both public policy and local clinics. While the government might pay for a one-time surgery, the ongoing daily costs of chronic illness continue to push families toward debt. Solving this requires a shift in priorities. It starts with a commitment to increase the public health budget to at least 3% of the GDP to rebuild the infrastructure in rural districts. Instead of just requiring doctors to serve in villages, the system should offer incentives, like modern housing and functional facilities, to make rural practice a viable career path. Technology is already beginning to bridge the gap. Telemedicine and artificial intelligence are now connecting rural patients with urban specialists, reducing the need for families to travel hundreds of miles for a consultation. We also need to move toward a preventative care model. Better nutrition, sanitation, and physical wellness can address many health issues before they ever require a hospital bed. India has the administrative capacity to do this. We saw it when the country systematically tracked down and eradicated polio. We saw it again with the scale and speed of the COVID-19 vaccination campaign. Consistent national growth depends on a healthy population. That requires a system where basic medical care is treated as a baseline requirement for every citizen, regardless of their income or where they live.